one.
Hi everyone, welcome to researchmd.com. We got another morning report presentation today. So let's hear the case.
84-year-old male.
Okay, we got an 84-year-old male. And what is the chief complaint?
Yes, presented to the emergency room for evaluation of gross hematuria.
Okay. So what is wrong with the statement again? We don't want to use like terms like, when you talk about like when you do a history and physical and assessment plan, it's an art. Okay, because 95% of the time your diagnosis come from history, right? So it's very important to use the patient term. I think I have mentioned that before. Instead of the hematuria, just use some words kind of in patient's words, because nobody's going to come up to you and say like, this is hematuria, right? So what did the patient say?
The patient had said that he had noticed blood in his urine
so
today morning.
Go back. So so say the statement again. So we got an 84-year-old male patient came with the blood in the urine.
Yes.
Right. So what are the things we need to know when somebody said like got blood in urine? What kind of questions we need to ask the patient? Right. Yes. What do we need to know?
Since when did he notice there was blood in the urine?
So when did it actually start? Okay. What else do we need to know?
Was it associated with pain?
Okay, why is that? Why is it associated with the pain? We should know.
Any renal stones?
Renal stone, that's like, one of the common causes could be like associated with pain. We need to know. What else? Do we need to know increased frequency of urination?
Yes.
Pain during the urination, we need to know. We need to know because it could be a UTI also, right? There's like a huge differential diagnosis we're going to talk about. So the question is going to be kind of framed towards that. Okay, right. So the next thing we need is let's look at the differential diagnosis of like, now we have like, we say like hematuria. What's our differential diagnosis? Let's go through that. It's a huge list, but we're trying to break it down. Okay. Oh, before we start on the hematuria, what else we need to know? Do we need to know anything about, the urine, like anything anybody know? But always you should ask the questions to find out what questions do you need to ask the patient to find out where the bleeding is from? What kind of questions can you ask?
Need to ask about his diet, like if he's taking.
Yeah, very important. You have to come back at diet and social history, like what is he taking? Diet history is important, right? Which drug? Which diet can change the beetroot? If you have taken beetroot, can color change into? Right? That's what important. But also what I was going to say is like ask about what happened if he said like I'm having blood in the urine in the initial phases of the urination. What is that? What is our differential diagnosis at that time? Anything kind of urethra. Okay, the blood is coming. If somebody said I'm trying to urinate and the blood initial phases of the urine, there's always kind of urethra. Okay, and somebody said like throughout when I do urinate, then you have to think about like the kidney and those and all that, okay? And those parts and all that. And let's say if somebody said like I'm finishing the urination and then I notice blood and all that, most of the time it's like prostatic or like, that could be the differential diagnosis. Just remember that. Okay, so we got like, let's look at the hematuria differential diagnosis. Hematuria, so we can usually kind of put them into two categories, okay? Glomerular diseases, and then your non-glomerular diseases. Okay, so let's talk about glomerular diseases. Like what are the most common thing in the glomerular disease we have to worry about? Everything is kind of immune mediated, right? What about like IgA nephritis, right? That could be IgA vasculitis, right? That could be the other one. And then what else? What about lupus?
Yes.
Okay, so let's write that. Tell me this again louder.
It's IgA nephropathy.
IgA nephropathy. Okay, what else?
PSGN.
IgA vasculitis, right?
Yes. Lupus.
Okay, lupus nephritis. So like those are the major things I know. There's a lot of other things also kind of immune mediated. So we'll say this is what? Immune mediator, right?
Yes.
Okay, and then what is like anti-GBM syndrome? What is that? What is they call it?
Good pasture syndrome.
Good pasture syndrome. And okay, so that could be like one of the other things and all that. And what are the other things you have to worry about? What about small vessel vasculitis?
Yes.
So tell me some names of the small vessel vasculitis we can kind of think about.
Vaginous granulomatosis.
Small vessel vasculitis. Okay. What are the, is there Wagner's? Is
Yes.
that what, like, is that an acceptable term to use, my friend?
No.
No, don't use that.
Okay.
Okay. You be very careful. When you come to a residency program or anywhere, you could get into trouble.
Yes.
Okay. A lot of people, like, you don't want to get associated with the name Wagner. We'll talk about it later. So give me the real name. If you don't practice the real name, you'll never remember. What's the real name?
Granulomatosis with polyangiitis.
Granulomatous with the polyangiitis, right?
Yes.
Polyangiitis. Okay, what are the other small vasculitis?
Microscopic
Microscopic.
polyangiitis.
Microscopic polyangiitis. Got it? Okay, microscopic polyangiitis. Okay, what else?
Jerk straw.
Jerk straws. Okay. So, jerk straws. Okay, so these are the things, you know, when you talk about broadly, when you can say, like, you know, always kind of put into two different categories. Glomerular disease, now we talk about the, we'll just talk about the non-glomerular causes, okay? What are the non-glomerular causes? So let's say it's a different type of thing. What are some non-glomerular? Let's start with the kidney first, okay? What else could be in that region, in the kidney region?
Dr. Cheriyath, do we need to have post-streptococcal glomerular nephritis also in glomerular disease? Right?
Yes, very good thought. Excellent. Okay, so that's why post-streptococcal. So, what is the usual presentation for that?
They present with upper respiratory tract infections.
Post-streptococcal glomerulonephritis. Okay, very important, very good. Like, because you know, you patient usually have 2 weeks before they have, like, you know, strep throat, and then you have hematuria and all that. A good thought and all that. Okay, let's start with the kidney. What are the main things affecting the kidney can cause hematuria? Pyelonephritis. Can pyelo causes? Okay, we'll just put pyelo. Pyelonephritis. Okay.
Kidney
what
stones.
else? Kidney stones. Okay, and what else?
Cancers.
Malignancy.
Cancer,
Malignancies.
kidney cancer also, right? Okay, what else?
Polycystic kidney disease.
Yep, polycystic kidney disease, PKD, right? Polycystic kidney disease. What else can cause? You know, medullary sponge disease also.
Right.
Let's put that. Even though it's kind of rare, but good to know. Medullary sponge disease. Okay, those are the things mainly when we talk about finished kidney. Let's come on down a little bit. We talk about what? Ureter,
Yes.
we talk about bladder, and then urethra kind of thing. So another big topic. What is it, like ureter,
Mm-hmm.
bladder, and urethra?
Yes.
Okay, so what are they? I mean,
Ureteral stones.
yeah, let's start with the simple thing. What is it, like urinary tract infection,
Yes.
right?
Yes.
Let's start with the first one, like UTI, and definitely the second one is stone.
There could be some trauma.
Trauma, what kind of trauma usually? What do we usually call? Iatrogenic trauma, right?
Iatrogenic.
Or like we usually, like what happens, you know, we put a Foley catheter, everybody come in the hospital, automatic, you know, they just kind of put Foley catheter. Be careful about it. And that can cause trauma. And that can cause like, what else? We talk
Prostate
about?
cancer.
Huh?
Prostate cancer.
No, we'll come back to prostate. We'll come back to that.
Okay.
We're just still in the ureter,
Okay.
bladder, and urethra region, right? What about bladder? If we talk about bladder cancer, right?
Okay.
That is what is important. Okay, bladder cancer. Okay, when you talk about bladder cancer, why should we, like, what is the thing we need to worry about in this patient?
His
You got
occupation.
an 84-year-old, right? We know, like, older age and a male patient. What bladder cancer is common in what group? Male,
Male.
right?
Yes.
It's very high in male. And this is becoming the 4th common cause of cancer in male in the United States, okay? So it's very important to kind of think about bladder cancer. Somebody with hematuria, your job is to make sure the patient doesn't have any bladder cancer, okay? Very, very important. What else? We talk about bladder cancer. Maybe kind of, so you mean urethral strictures, right?
Yes.
Okay,
Strictures.
strictures, we can say. Okay, what about hemorrhagic cystitis? Right?
Yes.
Yes.
Cyclophosphamide.
Yep. It's common, like, you know, they usually, like, every exam is like a cyclophosphamide. What about radiation, right? Any type of radiation and all those kind of damage, right? radiation cystitis, right? So we did that. Let's talk about the other. So we covered, the kidney and the bladder, ureter, and the urethra, and all those kind of things covered, right? What is the adjacent structure is the prostate.
Prostate.
Okay. What is the most common for hematuria in prostate, like BPH?
BPH.
And of course, you can have like prostate cancer
Cancer.
also, right? BPH. And then you have prostate cancer, right? And then look at what are the other causes? Like, some other causes like, other causes like exercise. Can the exercise cause hematuria? Right?
Yes.
Heavy
Yes,
exercise can,
exercise.
so it can cause like exercise-induced hematuria. Exercise-induced hematuria. Okay, now we talk about this broad differential. We talk about the glomerular diseases and the non-glomerular diseases, right? Now before we go into any further, let's look at what condition can mimic, hematuria, right? Let's start, give me some conditions you can have like a mimic hematuria. We'll just write it over here. Mimics. What condition? Right? You already said like when you take like a beetroot, right?
Yes.
I mean, some of the colored food you take,
Yes.
or a beetroot,
Yes.
right? What else?
Any drugs like rifampin,
Huh? Rifampin,
Yeah,
that's
or-
good cause, right?
orange color.
I mean, this is more like a orange color.
Right.
So just kind of we forget that. It doesn't usually we'll don't write that. What about rhabdomyolysis?
Yes.
Or myoglobinuria, right?
Yes.
Usually, like what happened? Patient, right, will come back like, what happens? The myoglobinuria, what else could be like some of the other causes? Right? Porphyria,
Yes.
that can cause. Like, a lot of times you can be like, maybe sometimes you can be menstruating female, right? Right?
Mm.
And then you have to be also fictitious, right? Some people try to make it, some people try to, they're going to come up with something to get away from the police or something, or some benefit to it. That's what I'm trying to say, okay? So that's what's important. So we got all of this. Let's move on. Let's move on. What else we have? What is the next? So we talk
Yes.
about, tell me about the past medical history.
Yes, so patient had COVID.
Okay. So we patient had past medical history, we just say COVID. Why is it important to us? Right?
Yes.
COVID can cause hematuria, nephritis.
Yes.
Yeah.
Yes.
I mean, COVID can cause a lot of things. In one of
Yes.
them also, a lot of people usually come with, they can throw a massive emboli everywhere and those kind of things. Kidney disease is very common also. What else? The
He
patient
has
is
a
on?
bilateral hearing loss.
Bilateral hearing loss. Why is this important? Bilateral. Give me one disease: bilateral hearing loss and hematuria. What disease is that?
Alport's.
Alport syndrome.
Yes.
What else they have? What happened to the eye in Alport syndrome?
Cataract.
Cataract.
Cataract. So remember the
retinopathies.
triad. Okay, very very important to know. So what else? Any other thing we need to know?
The patient also has diabetes.
Okay, we know it's the patient of diabetes. Okay.
Hyperlipidemia,
Usually
hypertension.
more like what? Nephritic syndrome or nephrotic syndrome in diabetes? What is that?
Nephrotic.
Nephrotic.
More like a nephrotic syndrome. Okay. What else?
Also has stage 3B chronic kidney disease.
Okay, CKD will write.
Yes.
Okay. What else?
That's it.
That's it.
Yes.
Okay. And then talk about what is the next thing?
Vitals.
Huh?
Vital-
Let's talk about
physical-
allergies.
Okay.
Yes, the patient does know no
No
allergies.
allergies. And then talk about family history. Why is it family history is important? Then we come back to the medication. Why is the family history important in somebody with hematuria? What are the things can can
Polycystic
cause?
kidney disease.
Huh?
Polycystic kidney disease.
Polycystic kidney disease is like very important. What else? Alport syndrome also. Okay?
Right.
Those are the two things we need to know. Polycystic kidney disease. I'm not going to write it, but think about it. Those are the differential diagnoses we just need to know. Okay?
Okay.
Yes.
And then what about medication? Why is it important in this patient, the medication?
Sometimes medication could also cause hematuria.
Yeah, we already said the color can
Cyclophosphamide.
change, nitrofurantoin, and those kind of things. Color change is very important. You always had asked, did you start any medication kind of recently also? Right? So tell me what medicine patient is on.
Yes. The patient is on hydrochlorothiazide,
Okay.
hydralazine,
Uh-huh.
amlodipine,
Mm-hmm.
rivaroxaban,
Uh-huh.
and clopidogrel.
Clopidogrel. Okay. What else? Or rivaroxaban, you said, right?
Yes.
Why is it important?
Anticoagulant.
Right? Can they cause blood bleeding?
Right.
Yeah, it can cause like bleeding also. Okay, we talk about medication. Now let's talk about the social history. What kind of things we need to know in the social history?
About his.
History of smoking and
Smoking.
History of smoking, why is that? Why is it important? Is he a smoker?
No, he's not a smoker.
He's not a smoker, negative smoker. Why is he a smoker? Again, smoking is associated with cancer. It could be
Yes.
like, bladder cancer kind of thing. What about the work history? Do we need to know?
Occupational
We already
history.
said like, we got the cancer. Is the fourth most common cancer in the United States is bladder cancer. So what are the other things associated with the dye, right?
Dyes.
Dye
Right.
use or any kind of chemical, we need to ask the history. Okay? And then, do we need to know about the sexual history? I mean, you can have like sexual, like you have like, sexual trauma and also can cause and all those kind of things. Okay, if it's
Yeah.
a female, always kind of say like menstrual history is also very important because
Right.
a lot of time maybe like it's contaminated with the menstrual blood and also is kind of thing. What is the travel history? Why is it important? The travel history. Why is it important? Schistosomiasis is like
Okay.
one of those things can cause like bladder
Bladder
irritation,
cancer. Squamous cell carcinoma.
yeah, cancer and all those kind of things we need
Right.
to know. Anything else we need to know? Okay, so he's okay, like no
Yes.
alcohol, no okay,
Mm.
and
No,
then
non-alcohol.
okay, and then psychiatric history, anything?
Not significant.
Okay, okay.
Yeah.
All right, so let's go and what are the things you have to know about the
Vitals.
vital signs?
Yes.
So tell me the vital signs on this patient.
Patient's vitals were blood pressure was 151/78.
Uh huh.
Temperature was 97.9.
Uh huh.
Pulse was 58.
Mm-hmm.
Respiratory rate was 18.
Mhm.
And saturation was 95%.
Saturation 95%. Yeah, nothing unique in here, right?
Yes.
Mainly I'm just kind of seeing, is he orthostatic? Is he losing like a lot of blood? Those are kind of things kind of important. Now, you have to do the examination, right? If
Yes.
you don't think like what need examination, all this differential diagnosis we talked about it, right? So if you don't think about our differential, otherwise you're going to be wasting a lot of time and you can forget a lot of things, okay? So we talk about like what is the phase, what are the things you have to look. Somebody said, what are you looking for?
Pallor.
Pallor, always kind of like look it up and
Yes.
see pallor, there's anemia because there's hematuria. What else? Why is the nose examination is important to this patient? Why is that? What did you say? Like granulomatous?
Okay,
Polyangiitis, right?
Yes.
What is the nasal
Nasal
perforation?
perforation,
Septal
yes.
perforation is common. They can also have like hemoptysis.
Hemoptysis.
But in this patient, it's very important. We need to ask about shortness of breath,
Yes.
hemoptysis, and then you're trying to connect the lung and the kidney, pulmonary renal syndrome. Very, very things you need to connect to. Okay, don't forget
Right.
it. So we talk about that's important. And then
Yes.
what else?
So
On
on
exam.
examination.
Yeah, what else we need to think? Like, we also have to look at the abdomen, any kind of
Yes.
masses and all those kind of things. You always got to look at the urethral region, okay?
Yes.
Is there any damage? Don't, don't stop the examination of the abdomen. If you have to unrobe the patient, if it is a female, get a chaperone in there and do the examination of the vaginal region also. Sometimes you have to be very careful. Sometimes a lot of people get like a rectal bleeding and the, hematuria in females get confused with it, especially like elder and all that. So it's very important. Sometimes I do that rectal examination also when we talk about it, okay? So we did all that, everything was
Yes.
normal?
All normal, no significant findings.
No significant history and
Yes.
all that, okay? What else? So we just did all these
Yes.
things. So what kind of labs is important? Before we go into, somebody tell me what labs we should check.
CBCs
We definitely need CBC.
and
We need
renal
a
function.
BMP, right? We need to know it's a
Yes.
renal failure. We need
urine analysis.
Of course, we need urine analysis.
Yes.
What else? Is that it? Or you stop right there? Do we need to get an ESR?
Yes.
CRP?
Yes.
Vasculitis,
right.
right?
Vasculitis.
One thing you don't want, ever want to miss a vasculitis.
Yes.
Because the complications are usually high. Okay?
Yes.
So when we talk about the lab and, so tell me the hemoglobin. What's the
Hemoglobin was 11.2.
11.2. So
WB?
there is, okay,
WBC was 6.8.
6.8.
Platelets 195.
Platelet 195. Okay, so we know we talk about the hemoglobin. I think I just got let me rewrite it again. I got it like reversed, right? So what is the WBC?
WBC 6.8.
6.8. Hemoglobin?
11.2.
Uh-huh.
And platelets 195.
195. Why is it platelets important also?
Any bleedings?
Any bleeding, I mean, those kind of things, very, very important, right? Platelet. Okay, sodium, potassium. What is the sodium?
Sodium is 139.
139, okay.
Potassium 3.7.
3.7.
Chloride 107.
107.
Bicarb 22.
22.
Creat 1.5.
Uh-huh.
And urea was 32.
32. Okay. So we have, we have some abnormalities in here, which we'll kind of document it. Give me like another pen right here. So we'll say like what are the abnormalities, like a little bit of anemia is kind of going on. Everybody agree that? Right? And then we know there's a little bit of metabolic acidosis going on. We'll come back to like and all that too. We know there is BU and creatinine is elevated also, right? Do we have what are the other labs we have?
We also have INR.
Okay.
That is 1.6.
We got INR 1.6. Okay. What else? Anything else?
His glucose was 106.
And the ESR, what was the ESR? Forgot to check, so we have to check the
Yes.
ESR. Okay. Always kind of will come back. There's nothing wrong with like forgetting, but you need to understand the
Yes.
complications, right? If you miss a vasculitis patient, the mortality rate, if you don't act on it, is huge. The patient with the granulomatous polyangiitis, they could die, and there's nothing you can do once the damage is done. Very, very important. Okay. And then what are the other investigations? What would you
Urine
do?
analysis.
Urine analysis. Okay. Tell me about the UA.
There was blood in urine. There was large.
Large blood. Okay.
Yes. WBCs were 15 to 20.
Okay. WBC 15 to 20.
And RBCs were too numerous to count.
Okay,
numerous
so large
RBCs.
blood and
Yes.
there's like a WBC. Why is it WBC? Like anytime WBC greater than 5, that means like you're concerned for UTI. Okay, so very good. But WBC has to greater than 5. What else I'm looking for in the UA? Let's say I'm checking glomerulonephritis. What is the thing I'm looking for?
The color.
No,
RBC cast.
RBC
Cast.
cast, right? Did they mention you about the RBC cast? No? Okay, that's where it's important, right? We
Yes.
need to know any, because it's a huge differential diagnosis. It's even though it kind of looks very simple, but it's not, okay? Very, very important to know.
RBC cells are too numerous to count.
RBC?
Yes,
Yeah,
it's
they're
too
too-
numerous.
Too numerous to
Yeah.
count. Okay, large blood, RBC, too numerous to count.
Numerous.
Okay. So, okay, any other investigation would you do in this patient? Do we need to get a chest x-ray? And why is it important? Is somebody with hematuria?
Oh,
If you complain about shortness of breath or hemotysis or examination kind of complaining about like nasal, nasal problem and all that, and then it'd be like reasonable to check, right? And also probably like a CT or something to look at, or abdominal. I would just go with an abdominal ultrasound. They do an abdominal ultrasound or anything to make sure there's no kidney, right?
Yes.
Kidney stones kind of associated with it. That's a reasonable test. Kidney can cause bladder cancer kind of CT, but again, you don't want to radiate. Let's say if you're looking for like a stone, what kind of CT scan would you do? With the contrast or without contrast?
without contrast.
Without
Without
contrast,
contrast.
okay? That's the only way kind of light up. So always kind of do like a without contrast you need to do. But again, what is the reason you don't want to do a CT in this patient? Look at the creatinine. What's going
Yes.
to happen if you're like a CT?
Right.
So an abdominal ultrasound would be like, I don't think they did it in this case.
No, they did
Okay.
not.
With all this thing we have, let's come into the assessment and plan. What do you think our number one assessment, number one diagnosis, right? At this point, based on, there's a lot of still, this case is not completely very clear. So we need to know, like, based on what we have, what can we say? Number one, we can say like hematuria, right?
Yes.
Everybody agree that?
Yes.
Right? And the patient on anticoagulation, INR is elevated, patient is on rivaroxaban,
Yes.
right?
Yes.
We can say that. Patient is on rivaroxaban. The anticoagulation itself kind of can cause like bleeding. This may be causing the bleeding right here, right? Maybe
Yes.
like getting an ultrasound of the, then we just kind of talk about what the investigators now. Check an ESR, right?
Yes.
We need to make sure there's no vasculitis.
Yes.
Right? Repeat a urine analysis maybe. I would repeat UA. And then would you get an abdominal ultrasound?
Yes.
It's reasonable, right?
Yes.
Abdominal ultrasound. Okay, what else we need to do? Do we need to put the anticoagulation on hold?
Yes.
Right?
Yes.
Just to make sure like what's going on first. Hold the anticoagulation. Right? Okay, what else could be the hematuria? What else can you link? There's a, I mean, is there
Infection.
an infection, right?
Yes.
Could be like a UTI also, right? This could be UTI possible. Another differential diagnosis could be. It's still not like very clear on all that, okay? Hold the anticoagulation. And what is the other thing? And then do we need to check the hemoglobin, right? And then I
Yes.
will also write check hemoglobin maybe like Q8 hours to make sure that is stable, right? And then what is the other thing we need to worry in this patient? Let's start with the renal failure, right?
Yes.
So what is the like you got renal failure? We need to know is acute or chronic, right?
Yes.
So CKD is there, right? You can just getting an abdominal ultrasound or it's like, you know, anyway kind of thing, follow up on the abdominal ultrasound. We need to know previous creatinine. So, right? We talk about the previous creatinine. Do we know about the previous creatinine?
No.
If you don't know, just go back to the chart and find out, you know, or call his PCP to find out what's previous creatinine because it's very important, right?
Okay.
Okay, and then what else? What are the other things going on? UTI, right? Is it symptomatic UTI? It's not, he didn't
No.
have any fever
No.
or any of those. He did not have a WBC count, right?
Yes.
Maybe, I don't know. There's no need, nobody checked any lactic acid. So that's not important. Maybe like, you know, maybe just culture it if you want to. I would not put this patient on antibiotic at this point. Okay? I say like asymptomatic. Can we say that?
Right.
Yes.
Okay?
What about
You guys
ABG
need to
doctor?
speak up. What is our number 4 up here? What is the other abnormality? Remember, I said every abnormality. That's why I circle it, right? Or like when I write like an HNP, every abnormal, there's a million things to learn from the labs. Okay, and then there's a good doctor is putting the physical examination, the labs, and the history together come with a great diagnosis, right? So let's see, like, I mean, they will say anemia, right? We don't want to forget anemia. Why is the anemia in this patient? Like, we know it's the hematuria, right? Will be like, we'll just say blood loss. Is that okay to say blood loss?
Yes.
Why should we worry about anemia in this, like an elderly patient come with anemia? What is the most likely diagnosis? You have to be like malignancy, right? Always make sure you do a colonoscopy and those kind of things. Very important kind of thing. All right, next thing is what? We see, we already talked about renal failure. What is that? Metabolic acidosis. Okay, so what's the first thing to do? I mean, it's not a big...
ABG?
Okay, you said ABG?
Yes.
Okay, why not? We should not do an ABG. Why is that? Okay, the reason, what are you looking for? Like, what additional information are you going to get in arterial blood gas? Which one is more accurate for metabolic acidosis? Okay, it's the BMP. Okay. When you do, I mean, when you look at the ABG, it's only like a calculator version. So to look at the metabolic acid, only thing is kind of beneficial if you want to look at the pH. We know there's a small acidosis. The pH is not going to be that much. Let's say, when do you do an ABG? Okay, that's a great question. Let's say if you do this here, this one came back like 7, 8, or something like that, right? Then I need to know what the pH is. That time I just go and do an arterial blood gas to look at the pH. At this point, with small thing, I know BMP is more accurate than to calculate the bicarbonate. Then I will say like metabolic acidosis. But what is the next step you have to do? You have to think it's an anion gap or non-anion gap metabolic acidosis, my friends. Okay? So what is this? Anion gap or non-anion gap metabolic acidosis? Somebody calculate and tell me.
Okay.
Right?
Yeah.
What is it? I mean, it's always like the, okay?
It is 10.
Okay, it's all, okay. Anion gap is 10.
Sodium.
All right? What is the normal anion gap?
10 to 12.
10 to
10 to 12. So it's like, can we say like a normal
Yes.
anion gap? So what is the next thing I do? I write NAG, right?
Yes.
Non-anion gap metabolic acidosis. Okay? Now I have to come up with everything, every abnormal value that has something to do with, you know, we have to come with an explanation. Okay, so we cannot just say like, oh, now I know is non-anion. I'm like, you know, I'm the greatest doctor and all that too. But now you need to tell me what are the causes of non-anion gap metabolic acidosis.
So
What else? What's the classic drug it can cause? The mountain sickness.
Acetozolamide.
Acetozolamide or Diamox, right?
Yes.
That's what, like, when you have severe metabolic alkalosis, they give it to bring the bicarbonate down. Okay,
Yes.
that's like, I mean, if you know your pharmacology, you can go back acetozolamide. The most common, I would say, diarrhea. Okay, diarrhea is like, and even IV fluids can cause it. Okay, but why should, like, I mean, can you link? Remember, everything you have to link with us. Can you link a non-anion metabolic acidosis and the past medical history? Anything in the past medical history, you can make a link.
CKD?
Huh?
CKD?
CKD most of the time is kind of like, more like an anion gap kind of picture. Okay. What about diabetes? What's the link with the diabetes and metabolic acidosis? What is the question? If I have to ask somebody, what do I write? Renal tubular acidosis, my friend. Okay. Diabetes can cause renal tubular acidosis. So if I'm writing a question, if I say I can link all this metabolic acidosis, okay, and the metabolic acidosis together with the renal tubular acidosis, though, and I have to know, like, I can say maybe it's like renal RTA, right?
Yeah.
Usually it's like type 4 is renal tubular acidosis, and you can see like hyperkalemia and all that. Okay, so I'm just guessing. That's like a big topic we need to kind of talk about it. So think about non-anion metabolic acidosis. Board question may be a question about patient come with a diarrhea, or patient maybe like, acetozolamide or Diamox they call, or then it's going to be like, one thing I always can remember is the renal tubular acidosis, right? You have to think about, like, another question is like, I think we have made a presentation before, Fanconi's anemia also, right? But in this patient, those are the things, and we just close it up, okay? So the main point you have to think about hematuria is always think about the huge differential diagnosis. I can tell you, a lot of times, I've been in this practice for a long time, the mistakes we make are so many, okay? Most of the mistake people make is missing vasculitis. Okay, if you miss like granulomatous polyangiitis, the patient or the mortality rate, if you don't treat it like right away, right, you just kind of go like 80-90% mortality, because we did not use our brain. Remember that. Also, what is the other thing? When a patient come to an outpatient practice and come with a hematuria, what is microscopic hematuria? Anybody know? It's like if it is greater than 2 RBCs, then you can call it microscopic hematuria. Okay. What is the most common, like, primary care doctors make the mistake of? Somebody come with a man come with hematuria, right? They just kind of ignore like it's like a BPH. I remember a patient, somebody ignored it, hematuria, and what happened like 3 or 4 years later, the patient came back and he got like bladder cancer. Okay, unfortunately, the bladder cancer has spread into the wall and the lymph node, so they need to do like a 14 or 10-hour long surgery, all this urethral diversion and all that. Patient has to live with it. Remember because someone did not think about hematuria. So in this patient, I think, repeating urine analysis, when everything is kind of cleared, if it come back, maybe an outpatient basis, you can need to work up for what? Like malignancy, or like you do a repeat analysis to make sure, like, it doesn't, maybe like, they need to like a cystoscopy, those kind of thing. And then you need to make sure the vasculitis, something is going on. Usually don't put like, INR or like, what am I going to say is like, let's say if you have, just because somebody is on anticoagulant, they should not bleed. But in our mind, we are saying like, oh, he's on anticoagulation, but there should be, most of the time, there's an underlying mechanism, my friends. Remember, okay? Hematuria is a big topic. Okay, so many things we could learn from. Just think about the differential diagnosis. Thank you for watching today. And, if you have any comments about the management or anything you want us to teach, please add it in under comments so we can learn from you. So like a great way we can have a communication going on. And thank you so much for participating, and we'll be back with another presentation soon. Thank you.